So in the last couple of years, 3 different agents, amyloid imaging agents, have been approved. And the next question with that has to do with reimbursement and getting it out into the community. CMS, the Center for Medicare and Medicaid Services, made a decision that they said they would approve under coverage with evidence development. And so for the last 2 years, the industry partners and the Alzheimer's Association and CMS has been working intensely to come up with a protocol in order to test whether these compounds can be useful in normal clinical practice. So IDEAS was announced last week, a very exciting study, over 18,000 patients, looking at the effect of amyloid imaging for changing clinical management plan, and also to see whether it affects Medicaid usage. And so this will be starting next year, and we're all quite excited about it. What we're hoping to show is that the incorporation of amyloid imaging into the diagnostic evaluation of patients with dementia will help determine a more accurate diagnosis of these patients, which will lead to better treatments, a more personalized life care plan, the initiation of appropriate medicines if they do or don't have Alzheimer's, and the stopping of inappropriate medicines if they don't have, for instance, Alzheimer's disease. Well, amyloid imaging in general is new, so this is really a paradigm-shifting technology for the community that has been changing things over the last several years. What we see is that previously the diagnosis was made based on clinical findings. It was a clinical diagnosis, and the certainty of whether a patient had Alzheimer's disease or another neurodegenerative dementing disease was made on autopsy. Now we can begin to get more biomarker data in to understand which kinds of dementias patients have before they die. And so this is really, I think this is really important. There is an appropriate use criteria that's been brought out by a combination of the Society of Nuclear Medicine and the Alzheimer's Association, who are looking at the best use of this compound is probably for neurologists or physicians who are experts in the dementia field. And so it probably in the short term will not be indicated for general primary care physicians, but will be used in conjunction with neurology or a dementia expert. Okay, to that degree, it is. Neuraseq, for instance, is available throughout Europe, throughout the United States. It is widely available. We have a global network, and physicians can order this throughout the United States. So I think that there's been traditionally sort of a nihilistic approach to this, and I think the community, and this is one of the things that I think is quite exciting, is becoming much more proactive. So even though there's not a cure to the disease, doesn't mean that you can't care for these patients and develop a personalized, appropriate care plan. And so there are medicines that help the symptomatic, the agitation, the insomnia, some of the behavioral changes. There are medicines available for that. Importantly, many of these patients get drugs that aren't appropriate, and so it's important to know the right diagnosis so that you can avoid compounds that are not appropriate for that patient. Particularly, one of the real strengths of the amyloid imaging agents have to do with making sure that something that you think is Alzheimer's disease isn't, because those patients might have treatable disease. They might have depression, they might have other diseases which are treatable. So it's very important to distinguish whether this is an Alzheimer's disease or not an Alzheimer's disease.